you very much, Mark. Now, although I've already extended this introduction just previously, the Honourable George Smitherman, Minister of Health and Long-Term...
I want to start by saying it's a privilege to have a chance to be here at Rogers on Bloor Street, which for the riding of Toronto Centre Rosedale, which you are in right now, has for a long, long time been perceived as a divide between the affluent and those less affluent. Now, I live south of Bloor in Cabbagetown, and obviously, as a result of condominium development and all of that, the south end of the riding has come up several notches. But a lot of people still get hung up on the Bloor Street divide because Rosedale is to the north, and I'm going to return to that in a second. Firstly, I want to address the title. Private versus public care, does it really have to be one versus the other? I think that there's a lot of talk going on in healthcare today, and there are a lot of these sessions, and I try to come to as few of them as possible because they don't really provide me with very much of an opportunity to talk to real people, to talk to patients. And I just want to say I think that we have an obligation, and I'm delighted that there's a television camera that is at least recording this event, to recognize that at the heart of this is not just our own individual interest, but the reality that there are 12.5 million patients in the province of Ontario. And I'm obligated every day to do my best on their behalf, and more particularly to be a voice and representative for about 125,000 of those people who are privileged to live in downtown Toronto, and I'm privileged to be their representative. I think that there's a danger that the title, it says something like private versus public care, sets us up for a fake debate, and I'm not really interested in them. The other panelists have been, I think, very clear to say that here in the province of Ontario, I think Karen Sullivan is here from the Ontario Long-Term Care Association, we have a very, very significant degree of private delivery, for-profit delivery, in the context of our universally accessible public health care system. And I think that amongst many people who participate in these debates, they use language to frankly skew the debate to unreal places. The reality is that the challenge that I think that we must address, some people use the word equity. I think that there is a misappropriation of phrase deliberately, very often in this healthcare discussion. And I think that at heart, we really must relate these issues in the context of two-tier. And I will seek to do that through the course of the discussion today. Another element of the debate that I think is a bit fake, and I want to challenge my friend Dr. Greg Flynn on this point, is that if we read back his remarks, we would pretend that as we sit here right now, there are not hundreds and hundreds of Ontario doctors that he represents engaged in tremendously powerful and meaningful innovation in the context of our public health care system. If the debate is a fake debate, if the discussion is such that anybody pretends that I am a voice or representative of the status quo, because I know in our one-to-one meetings there's no suggestion that we're doing things the same. In fact, there's tremendous challenge placed on the very healthcare system in the province of Ontario. Challenge to address the very same thing that we're all here to talk about and that we all agree on, is that patients are facing challenges to access that are not appropriate, and that none of us would wish for a system that our government likes to describe as the best expression of Canadian values. And Mark Keeley, I think, spoke about that as well. I want to say that when I think about Toronto Centre Rosedale, I have the privilege of representing many of Canada's richest and too many of Canada's poorest. And I have an understanding that is that wealth is already a tremendous influence in the context of population health. And let's not pretend about that. I am someone that, in the grand scheme of things in my riding, is not amongst the wealthiest. But I must remind myself always that if I look at the pattern of income, I am in the top percentile of income earners. And I think accordingly it's important for us in this audience and on this panel to self-identify in a similar way. I recognize that when I go to Regent Park, an underlying degree of chronic illness, very much of which is related very directly to poverty. And I think it's crucial that we don't pretend. And Doris Greenspan touched on this when she spoke about the context of overall social spending. There are many things that are determinants in the quality of health, and accordingly, I think that the obligation to make sure that those in our society who suffer and struggle with more underlying health challenge are not forgotten in this discussion. They are not present in this room today, but they will be present in my conversation because it's my obligation to represent them. And it is a challenge, I can assure you, and I have a chance to understand it well in a riding which offers such extraordinary economic diversity. We cannot all pretend to be the voice for patients. If we hear the patient's voice articulated, we hear everybody articulating in a fashion that works well for them. As government, we are elected, and we were elected by the people of the province of Ontario in quite significant numbers in 2003 on an agenda to address wait times. And I'm very proud that Dalton McGuinty put this current iteration of the wait times agenda on the national agenda. It was our party, as an opposition party, that led the wait times initiative. And it was our premier, in his role as chair of the Council of the Federation, that really did seek to create a new impetus in our land for improvement on this issue. And what bothers me more than anything else, that the risk that grips me more than anything else, is that because so many of us, or you, are involved in helping to focus the debate on the desire to enhance the proportion of private delivery and perhaps to advance models around two-tier like the Koopman model, that you lose sight of the reality that's out there for patients and of the obligation that a government has to address those circumstances. I'm going to leave early today. Well, I see that when the Fraser Institute doesn't show up and Koopman doesn't show up, it kind of reminds me of the 1999 campaign when my Conservative opponent wouldn't come to all candidates' debates and participate. But I'm going to go to a real meeting, and I'm going to meet with the mayors of Harrow, Leamington, Chatham, and Tilbury. And if anyone knows that part of southwestern Ontario, they'll know it as an area that really does struggle with physician supply challenges. It's a real tough spot. And what we're building in those 4 communities are family health teams that are designed, quite frankly, to do many of things, to advance in the very, very direction that Mr. Koopman's representative speaks to today. And that is the capacity to deliver more interdisciplinary care, to build teams, and to rely on a broader array of healthcare providers to assist people both with a more comprehensive range of services, but also to expand through that team the capacity to provide care to some of those in those communities that are not able to experience it now. The preventative focus is one of the things that is at the heart of our government's agenda, and accordingly, I think it's a fake debate if anyone suggests to you that the discussion is either we move more into private or we accept the status quo. I am not an agent of the status quo. I am representative of a government that has been quite demonstrative in our desire to innovate within the context of the public healthcare system, and I think we all have to be very, very careful to deprive Ontarians and other Canadians of an understanding that while we recognize that there are challenges, that there is actually all across the land in some significantly and minorly different ways, tremendous progress. And I just ask all of you, as you may be advancing an agenda or two, not to forget that in healthcare today, as we are in this meeting, all across the land, there are thousands and thousands and thousands of healthcare providers who are seeking new ways to innovate to address the challenge that we all agree is a challenge that must be addressed, and that is around some of those circumstances where access is not being provided in a sufficient way or in a timely way. And I think that the question in the debate in the heading, private versus public care, does it have to be one versus the other, is not, frankly, a very, very accurate reflection on the reality. We cannot pretend that in the province of Ontario we are not already using, in a variety of different ways, a significant amount of private, for-profit care. And some people would pretend that that's not the case. I want to make the case very, very clearly on the challenge with the Koopman Clinic. The Koopman Clinic suggests that the ratio of doctors would be 1 doctor to 500 patients. The Ontario Medical Association would tell you that approximately the average proportion of service right now in a fee-for-service model is 1 doctor for 1,300 patients. What we have before us in the Koopman Clinic proposal is that for each clinic open, the one in London, proposed, the one in Toronto, proposed, the one in Ottawa, proposed. For every one of those clinics with 9 doctors, 4,500 patients will be left behind, orphaned in the public health care system. In an environment where one of the most serious challenges we face is a shortage of family physicians, and we have taken considerable action to seek to address that. A 23% expansion in the size of our medical schools, 200 spots for our foreign trained doctors and family health teams as a model to deliver broader care. In an environment where we all acknowledge that there are too few physicians, I really think it's incumbent upon those who are proponents for a 2-tier style clinic like the Koopman Clinic to explain to us how